Afternoon. Thanks for coming. So I'm going to talk about psychotic symptoms in neurodegenerative disease. Just an outline of the progression of the talk. First, we're going to do some questions. Then we'll talk about some definitions of the overall topic as well as definitions of words within that topic. Then we'll talk about some of the causes of psychotic symptoms in neurodegenerative diseases, how we evaluate psychotic symptoms and how we manage them. And then we'll have a little bit of discussion at the end. So first, questions. I'm going to ask you questions. What does psychotic mean? Anybody want to volunteer? Shout something out. Mrs. Bazaganvali?
Uncontrollable rude things.
Uncontrollable
rude behavior.
Uncontrollable rude behavior, okay. Anyone else?
Yeah, delusions and not seeing the world the way we would like people to see it.
Delusions and not seeing the world the way we'd like people to see it, okay. Any other thoughts? Okay, how about questions for me before we start? Does anyone have any questions that you'd like me to address about psychotic symptoms before I get into the talk? Nothing in particular on your minds? Okay. All right, so let's go ahead to definitions. So, psychosis as medically defined, probably most of us in this room have said to somebody at some point in time, you're psychotic. Or has said, well, I'm not psychotic. But when we say psychosis in medical terms, we're not talking about being agitated, not being overactive or hyperactive. And we're not talking about someone just quote unquote going nuts or just acting in a way that we wouldn't like them to act. And we're not talking about someone being obstinate or difficult either, or just acting up. But psychosis has a specific medical definition, and that definition, psychosis is a disturbance of one's or an individual's contact with reality. And another way of saying it is that it's a disruption in the way that someone experiences the world. It's a change in the way that someone is interacting with the people, the objects, the experiences that are going on around them. And there are specific elements of psychosis. So when we talk about psychotic symptoms, we're talking about one, perceptual disturbances or false perceptions, which are hallucinations and illusions. So a hallucination is when someone has a perceptual experience that is generated in their own mind. An illusion is when someone misinterprets a perceptual experience. A classic illusion that we've probably all had is seeing a shadow of something and thinking it's something that it's actually not, right? Wake up in the middle of the night, there's a shadow of a coat or something like that, and you think for a moment it's a person. That's actually an illusion. And in some situations, it can be considered a psychotic experience if you're unable to do what's called reality testing and change your mind and realize what that really is. So if you persist in that thought that, oh, that was a person, as opposed to the shadow of a coat, then it's a psychotic experience. So these perceptions can occur, false perceptions can occur in any sensory modality. Visual, auditory, tactile, which is touch, so a sensation of feeling something that's not actually there. Gustatory, which is tasting something that you're not actually tasting. And olfactory, smelling something that's not actually there. And all of these occur in neurologic diseases. The most common type of hallucination that occurs across neurologic diseases is auditory. But visual hallucinations have a particular neurologic significance. Then another element of psychotic symptoms is delusions. And delusion is different from a hallucination, is that a delusion is a fixed false belief. And it's important to recognize both components of that. Not only is a delusion false, not true, but it is also fixed. It's not amenable to convincing someone or arguing logically about what they believe. And there are some of these that are really common in neurodegenerative diseases. Probably the most common one that we see, and we see it particularly in Alzheimer's disease, is the delusion of theft. And we think this occurs a lot in Alzheimer's disease because of the particular memory disturbance that occurs in Alzheimer's disease. People forget where they put things. If you put something down and you know you put something somewhere and then you go and it's not there, what other option do you have than to think that someone took it, really? So in some situations, these delusions might make a little bit of sense, right? Things don't just disappear. And some of you, if you've taken care of individuals with Alzheimer's disease, you may even have heard them say that. I know I put it here. Things don't just disappear. Someone must have taken it. Well, who could have taken it? Well, who's in the house with me? You go through this argument, and it's logical. If you start with the premise that my memory is fine, then you have no other conclusion to draw except for the fact that someone moved it. Delusions of infidelity are also common. So if you say to someone, if I say to my wife, I'm going to the store, I come back an hour later and she says, where were you? I told you I was going to the store. No, you didn't. Yes, I did. Sorry?
It's in the genes.
You mean it's on the X chromosomes? If you have an extra X chromosome, then well, if you forget that I told you, then when I say I told you, you think I'm lying to you, right? So I think that's another reason why delusions of infidelity show up a lot in Alzheimer's disease. People forget that I told you where I was going, or they forget how long you've been gone. I've only been gone an hour. You've been gone all day. Well, no, I haven't. And you weren't here last night either. Yes, I was. It's important not to argue with delusions because, again, they are fixed false beliefs. Phantom boarder is another one. Well, if you didn't take it and I didn't take it, there must be someone else here who took it or moved that thing or is making that noise that I heard. Delusions of persecution, not so common in Alzheimer's disease and other neurodegenerative disorders, but very common in other neuropsychiatric syndromes. Then there's an imposter delusion, otherwise known as Capgras delusion, where you think someone you love has been replaced by an imposter who looks a lot like them, but isn't really that person. We see that a lot in Lewy body disease. Delusions of nihilism, where everything's been replaced or been emptied out. Sometimes these people think that they've been completely emptied out. I had a patient once who insisted to me, he was wearing a short sleeve shirt and shorts, and he insisted to me that there was nothing underneath his shirt or his shorts, that all of him that existed was the arms beyond his shirt, and the rest of him was just gone, that nothing was there. Paranoid delusions, we've all heard about that. Some of us even call people paranoid. The thought that someone is trying to do something to harm you or watching you. Parasitosis. Anyone guess what delusions of parasitosis are? They often manifest as scratching.
Yeah.
What's that? Yell it out. Huh?
And osis means condition.
A condition, right?
Artificial scratching.
Artificial scratching. So they think
It is, but they don't.
bugs, yes. So it's a thought that you've been infested with something, with a parasite. So it can be bugs, and that's the most common, but it could be worms also. Some people think they've been infested, with tumors, so it doesn't necessarily have to be something that's a separate living organism, but they think that they've been infested by something or other. And then delusions of grandiosity, believing that you are greater than other people or greater than you actually are or have special powers. Some people really are greater than other people, but this is believing that you're greater than you actually are, you have special powers, you have a special relationship with either God or people of authority or something like that. A third element that is not as often recognized is abnormal thought processes. So these take the form of faulty logic, and sometimes they take the form of faulty logic that is based in the fact that people start with an incorrect premise. So if you start with the fact that I have a special relationship with God, then everything else that you think about might be faulty if you base it on that premise. Well, if I have a special relationship with God, then you don't. And then whatever you say that disagrees with me would therefore have to be a lie. And therefore, the way I think about what you say is going to be altered based on that premise. Sometimes it can be driven by impaired cognition. So the example I gave, if my memory is fine, although it's actually not, if I think my memory is fine, and I know I put something somewhere, although I didn't, I forget that I put it somewhere else, then my logic that's derived from that is going to be faulty also. People with psychotic thought processes can also be preoccupied with things that don't make a lot of sense. And sometimes you'll see disconnection of their thoughts. They'll be going along talking about something, and then suddenly they'll shift to something else. So that's what's called derailed thinking, where it's almost as if they're on a track heading one way and an engineer pulls a switch and they're on a track heading somewhere else. And when they get there, you can't figure out where they started. Irrelevant thoughts will come up. And then tangentiality, which is where one thought triggers a series of thoughts that you can see how they started off the thought, but you can't figure out why they went in the direction that they went. So it's almost like a bullet that hits a wall and pings off and goes somewhere else, hits that next wall and pings off and goes somewhere else. So why do people have psychotic symptoms? Well, we're talking about psychosis and neurodegenerative disease, so obviously neurodegenerative diseases can cause psychotic symptoms. Dementias commonly cause psychotic symptoms. Alzheimer's disease, like I mentioned a couple of times, very commonly causes psychosis, and I'll show you a couple of statistics on that. Lewy body disease, which is a little bit less common than Alzheimer's disease, but still one of the 3 most common dementias, is also a common cause of psychosis. So in Alzheimer's disease, psychosis most commonly takes the form of delusions, whereas in Lewy body disease, we tend to see visual hallucinations as the primary form of psychosis. In movement disorders, in Parkinson's disease, generally we tend to see visual hallucinations. Parkinson's disease is very closely related to Lewy body disease. In fact, Lewy bodies are what causes Parkinson's disease, just that the Lewy bodies are closely concentrated in the brainstem, whereas Lewy body disease, dementia, is caused by Lewy bodies all over the brain. So Parkinson's disease really is a Lewy body disease. It's just that the Lewy bodies are closely packed up in the brainstem and eventually spread all over the place. But they both cause visual hallucinations. And in Huntington's disease, which tends to affect younger people, we don't see visual hallucinations a whole lot, but we do see a lot of delusions in people with Huntington's disease. In all of these diseases, we see psychotic symptoms at a rate much higher than 30%. So really, really common. So here's a graph showing what happens in Alzheimer's disease. And there are a couple of things I want to point out here. One is that, well, let me first explain this graph. So each of these clusters of bars is a different neuropsychiatric symptom. So you have depression, agitation, depression, agitation, anxiety, and then our psychotic symptoms, delusions, and hallucinations. Each of these clusters, you have mild disease, so people with mild disease, and how frequently they have that symptom, and then people with moderate disease and severe disease, and how frequently they have that symptom. And in general, people with more severe disease have a higher rate of having the symptoms. See, the bars on the right tend to be higher than the bars on the left.
Do the numbers represent percent?
The numbers on the left represent percent, exactly. So 2 things I want to point out. One is that by the time Alzheimer's disease gets severe, more than 50% of people have hallucinations. So hallucinations are extremely common in Alzheimer's disease. But the other thing that I want to point out is even in people with mild disease, that more than 20% will have either delusions or hallucinations. So more than 1 in 5 people with even mild Alzheimer's disease have delusions or hallucinations. So when I say common, I'm not kidding. And although we think of these as being sort of the most severe or most extreme behavioral symptoms of Alzheimer's disease, they're not really that far behind these other symptoms that we consider to be really common, such as depression, anxiety, and agitation. So they really are occurring in a lot of the patients that we take care of. Another way of looking at this, this is looking at Alzheimer's disease 1, 2, 3, and 4 years after diagnosis, and how many people have delusions and or hallucinations. And you can see within 4 years of diagnosis, 50% of people will have delusions and or hallucinations in Alzheimer's disease. Again, quite common. More than half within 4 years. Within 4 years, most people are either in mild or moderate stage of Alzheimer's disease. Few people have reached severe stage within 4 years. Lewy body disease. Not only are psychotic symptoms common in Lewy body disease, but this is a listing of the diagnostic criteria for Lewy body disease. And in fact, 3 of the diagnostic criteria, visual hallucinations, delusions, and hallucinations in other modalities, so hallucinations that are not visual, auditory, tactile, whatever, are in the diagnostic criteria, so actually part of diagnosing Lewy body disease. So just to show you how important these symptoms are in sort of how we think about these different diseases. Although the diseases we treat can cause psychotic symptoms in and of themselves, we also have to think about the possibility that the psychotic symptoms we see in our patients are potentially being caused by other factors. So some of the medications we use could be causing psychotic symptoms. So medications that we use to treat movement problems, such as the dopamine agonists like Mirapex and Requip and Sinemet, those medicines can cause hallucinations, can cause delusions or make delusions worse. Treatments that we use to treat allergies like Benadryl and Atarax, those medicines are also used to help people sleep. Those medications can cause hallucinations. Sleep medicines like Ambien also can induce hallucinations. Stimulants, pain medications like the opioids, and muscle relaxants, all of these have the potential to induce hallucinations. And in case you think that's rare, I've seen every medicine that I've listed here is a medicine where I've personally seen hallucinations as a result. In a lot of our patients, we will sometimes, they'll be doing just fine, and then hallucinations will start over the course of a day or two. And sometimes it can be just because the illness is getting worse. But most of our illnesses, they get worse gradually. And when we see sudden changes, we think about things like medication changes, but we also have to think about illnesses. Very commonly, urinary tract infections can start rapidly and escalate rapidly and cause behavioral symptoms like psychotic symptoms, not just hallucinations, but also delusions. So suddenly someone becomes very paranoid or starts staying up at night looking out the window because they think they're seeing things. And it's because of a urinary tract infection or a cellulitis or a pneumonia. Mrs. Mandarino.
Why would a urinary tract infection cause delusions?
She asks, why would a urinary tract infection cause delusions? We don't quite know. The way we think about it is that whenever you get an infection or any kind of disruption in the metabolism, that there are both local factors, right? So you get inflammation in and around the bladder in the case of a urinary tract infection, but there are also systemic things that go on. You get a fever. So there's some kind of systemic response, and part of that systemic response also affects the brain. When you have a brain that's compromised for some reason, from Alzheimer's disease, let's say, the brain responds differently to this systemic response than it would have in the past. And so part of that response is sometimes paranoia, sometimes it's confusion, sometimes it's hallucinations. So we don't know exactly why, but we know there are inflammatory things that happen throughout the body when we get sick. The kind of thing that when you have a pneumonia or urinary tract infection, when you're a kid or when you're a young adult, make you feel crummy. That crumminess somehow in the compromised brain translates to confusions, hallucinations, delusions, paranoia, etc. Similar thing with metabolic factors. So dehydration, electrolyte disturbances, those can manifest also as psychotic symptoms. Sometimes, and I've seen this myself also, organ failure, like renal failure or liver failure, can show up as hallucinations. And when this happens, we call it delirium. When there's a medication or medical illness that causes someone to temporarily or suddenly become psychotic or confused, it's referred to as delirium. Stroke and seizure can also cause these types of symptoms. So what does an evaluation consist of? How do we determine what is causing this? Well, in people who already have a brain disorder, you want to have a high level of suspicion. So if you think that someone might have Alzheimer's disease and you see psychotic symptoms, obviously you have to have a high level of suspicion that Alzheimer's disease is causing their psychotic symptoms. You also have to have a high level of suspicion that some medical problem is causing their psychotic symptoms. But what about if you're concerned that someone might be psychotic and they're not showing overt symptoms? Well, you want to look for thought processes that don't make a lot of sense or behaviors that don't make a lot of sense. If someone starts doing things that just seem a little bit strange, you hear them talking when you know there isn't anyone else there, or you see them sort of doing this kind of thing when you don't see anything that they need to be tracking in the room. When they talk to you about things that you're not really sure what they might be talking about. They may either be talking about something that they've experienced sensorially that you don't think that they could have experienced because, you know, there wasn't a cat here yesterday. Or they're talking about things that are certain preoccupations for them that are brand new or that you didn't know about. Or if they seem to be scared of certain things, scared to go in a particular room, or they insist on driving in one car instead of another, or say don't turn on that street and won't explain really why. Those might be symptoms that they're afraid of something that is sourced from a paranoid delusion or some other psychotic experience that you're not aware of. And don't be afraid to ask about it in a non-threatening way. You know, what are you, nuts? Why not? That is not a non-threatening way. But, oh, how come? Or, are you sure? You know, ask about it like as if you're doing an interview, right? You've heard softball interviews before. Do a softball interview and try and find out what's motivating the behavior without necessarily blaming or assuming that the behavior is wrong. For all you know, they might know something that you don't. So approach it from that angle. So in terms of trying to diagnose what is causing psychosis, it always has to be approached in a logical and stepwise fashion. Obviously, you want to find out about what the current problems are that that individual has that might give you an insight into what is causing the psychosis. You want to find out what the symptoms are they might have. Someone walks into my office that I haven't met before, and they tell me, or their family tells me that they've been seeing things. My next step is not that I'm going to get labs. My next step is, well, are there memory problems? Are there movement issues? Trying to figure out, is there an underlying disease that might cause this? Okay, if there's not, is there something new that's happened that might cause this? Medication changes, any urinary tract symptoms, and so forth. It might be necessary to get some labs and some x-rays, because like I mentioned, medication change, electrolyte disturbances, dehydration, stroke, seizure, all of those things are possible contributors. And you rule these things out or rule them in by talking to the patient. Now, sometimes when there's a sudden change, you might get told, and this is very frustrating, I know, but you might call your doctor and they might say, listen, you need to go to the emergency room. And the reason is because some electrolyte disturbances, even sometimes when your own doctor has changed your medication and you report that you're having a side effect to it, there are some things that are emergencies and need to be treated as such. And there is no option except to go to the emergency room. So although it seems ridiculous, there are times when you need to report to the emergency room because delirium is considered a medical emergency. So other than treating delirium, what do we try to do about psychosis? Ideally, we try to manage it without using medications. And I'll talk about why we try to avoid medications in a minute. But if you think about it, if someone is having unusual thoughts, they're preoccupied by unusual thoughts, or they're preoccupied by unusual sensory inputs or sensory experiences that they're generating in their own mind, the thing you want to do is replace as much as possible those abnormal thoughts and those abnormal sensory experiences with normal ones. So although it seems like it might be best to put someone like that in a dark, calm room. In fact, the best thing to do is to stimulate them and give them lots of activity to replace the abnormal thoughts and the abnormal sensory experiences with normal ones, to actually keep them active and focused on something outside of the stuff that's being generated in their own heads. Try and distract them, in other words, from the distressing thoughts and the distressing images that they're having. Don't argue, because remember, these are, I mean, we're taught from the time we're born, right? I'll believe it when I see it. If someone is seeing something, you're not going to argue them out of believing what they're seeing. So don't try to argue with them. Don't try to argue out of delusions. What's the definition of a delusion? Anybody remember? Come on, it was like 10 minutes ago. What's the definition of a delusion?
Something that's not there.
It is something that's not there, so it's false. What's the other component to it? It's a belief that's false and what?
It's believed to be true.
And it's believed to be true and
you are expecting something and nothing passes.
and it's fixed. It's fixed. It is fixed, that's right. Thank you. It is a fixed false belief. It is not going to respond to argument. It may respond temporarily, sort of grudgingly. Okay, if you say so. But it is not something that you're going to argue someone out of. We can barely, occasionally we can medicate people out of it, but delusions do not respond very well to any kind of intervention. So don't argue. Probably the best you can do is agree to disagree about it and to sort of move on. Yes, I understand that you believe that, but we've got to get this or that done. So let's leave that aside for now. Let's not argue about it. Let's move on and do what we need to do. There is some evidence that maybe aromatherapy and massage may help, and I'll tell you about that in just a minute. We're not clear on whether those actually help with the delusions and hallucinations or whether they just help to reduce the agitation that delusions and hallucinations can cause. And then remember what your goals are. With people with neurodegenerative disorders, like everything else, we don't have cures, right? And with these psychotic symptoms, we're not necessarily trying to eliminate the psychotic symptoms. What we're trying to do is improve function and improve quality of life. We're not trying to eliminate the delusion. We're trying to make sure that the person is comfortable and happy, despite the fact that the delusion or the hallucination might be there, okay? It would be great if we could eliminate delusions and hallucinations, but I'm telling you right now that we can't always do that. And so the goal is to try and make the person happy and comfortable, right? If we can do that by getting rid of the hallucination or delusion, that would be fine. But remember what your goal is primarily is the comfort.
Excuse me, are hallucinations and delusions, are they always scary or are sometimes they comforting?
The question was, are hallucinations and delusions always scary or are they comforting sometimes? Important question. They are sometimes comforting. And often they're neither. They're just benign. So a lot of individuals with Parkinson's disease, for example, have benign hallucinations of kids walking by or animals walking by or people around. And, there are people who set the table for these folks, because they're very convincing. But that is another place where we sometimes have to do a little bit of help and intervention with the caregiver. If these hallucinations aren't bothering the patient, then it's okay that they're there. We'll do what we can to reduce their negative impact, but if they're not having a negative impact, it's not something to really address or get very worked up about. I have a patient who finds one of her hallucinations quite comforting. It's a guy who stands in her door at her assisted living facility, and she has this impression that he's watching out for her. It's perfect. Medication-wise, what are we able to do? It turns out that the medicines that we use to treat memory problems in Alzheimer's disease have an impact on visual hallucinations. So that's donepezil or Aricept, galantamine, which is Razidine, and rivastigmine, which is Exelon. Those three medicines do seem to reduce visual hallucinations in Lewy body disease and Parkinson's disease. So we try and use those. They tend to be relatively benign, although there are a number of patients who have side effects with those. And strangely, in patients with Lewy body disease and Parkinson's disease, occasionally we can see worsening of hallucinations with those medications. And then there are antipsychotic medications. You have psychotic symptoms, why not an antipsychotic medication? Well, they probably are the most effective treatments for psychotic symptoms, but they are definitely difficult to use. So remember, I told you why we try to avoid using medication if we can, and this is why, because the antipsychotic medications can cause pretty significant side effects. So neuroleptic malignant syndrome is a severe emergency. People get rigidity, fever, can go into coma. The mortality rate is around 20% from this syndrome. Luckily, it happens less than 1% of the time, but obviously, you know, it's not something we want to see happen, and it is a risk with these meds. They can also increase blood sugar and cholesterol, and they can cause movement problems. So particularly in people with Parkinson's disease and Lewy body disease, they can make the movement problems much worse. And if that weren't bad enough, in elderly people with agitation from dementia, these medicines have an increased risk of stroke and of sudden death. So they increase the risk from about 2% per year to about 4% per year. So even though that's still small, it is a doubling of the risk, and it's important to recognize that. Sometimes there are no alternatives, but you always want to try other things if possible.
Now, are you saying that the drugs that you're giving to control movement problems are causing movement problems?
The question is, am I saying that the drugs we're giving to control movement problems are causing movement problems? Not exactly. So the drugs that we're giving to control the behavioral problems in someone with a movement disorder can make the movement problems worse. So we never give these drugs to help with the movement problem itself. But in patients who have behavioral problems that we're trying to control, who also have a movement disorder, the medicines can sometimes make the movement problem worse, yeah. Which is why we really try and stay away from them. This is a study that was done looking at people who got put on antipsychotic medications, and they just looked at what happened to them in the first 30 days after they started the medicine. So, just want to look at this last column here, and this is people who had agitation with dementia and were put on no antipsychotics, put on older or newer antipsychotics, which are these, they're called atypical antipsychotics, and then put on older antipsychotics. And the point is that people who were put on antipsychotics had a huge risk within 30 days of having a serious event, which was classified as either a stroke, a fall or a hip fracture, or hospitalization for some other reason. 13 to 16%. I mean, that's 1 in 6 of these people who were put on these drugs. So again, we prefer to avoid them. The only situation in which we use these drugs first line is if someone is harming themselves or harming someone else. So if someone is actually assaultive because of their psychotic symptoms, which does happen sometimes. So if someone is actually committing harm, then we take the risk that, okay, these drugs may cause harm, but we already have 100% risk. We know that this person is hurting someone. So there is a little bit of hope on the horizon. There's a new medication called Pimavanserin that is an antipsychotic medicine, but it has a different mechanism of action from the other antipsychotics. And it was approved recently for use in Parkinson's disease psychosis. So it is not expected to cause the movement problems that the other medicines do because it doesn't block dopamine, which is what the other medicines do to treat psychosis. Now, we don't know, although the studies don't seem to indicate that it has the same risk of stroke or sudden death. We don't quite know if it's going to be free of that risk because it just doesn't have enough time or patience under its belt in the studies that were done, but it certainly does offer a much better option in terms of the potential movement side effects than the current medicines on the market. And it's expected to be released next month, so hopefully there will be an opportunity for people who haven't been able to tolerate these older medicines to try something new. So another option, besides targeting the psychosis itself, again, this is in the interest of improving quality of life and reducing the risk of harm to the patient, is to target agitation. And we frankly haven't done a very good job of distinguishing between agitation and psychosis. So for example, those studies I mentioned where the use of antipsychotics increased the risk of stroke and sudden death, those were in patients where what was studied was the use of antipsychotics for agitation. There actually aren't very good studies specifically on the use of antipsychotics for psychosis in dementia. But we sort of smear the results and say, okay, there's this risk there. But there are some good studies on using certain therapies for agitation. So antidepressant medications can be used for agitation. They work fairly well, and if you can reduce the agitation that results from psychosis, then sometimes that's enough. There are a lot of behavioral and environmental things that have been used. So redirection is sort of classic, kind of the therapeutic lying when someone's agitated, moving them in another direction, taking them to another room, telling them not to worry about whatever it is that's on their mind at that moment. When we say here to decrease the stimulation, usually we're talking about if they're focused on a particular object, a particular task, to take that stimulation away from them. So not a general decrease in stimulation. Exercise actually seems to be helpful. So regular exercise eventually lowers levels of agitation in individuals with dementia. Music therapy reduces agitation. Yes, sir?
I have a question. Has there been any research using recreational drugs like mollies, magic mushrooms, things like that? 'Cause I know they're starting to do some research on that. I don't know if they're doing it on this particular disturbance inside.
The question is, has there been any research using recreational drugs? So there's research using benzodiazepines, which has been sort of spotty. There's beginning to be research using marijuana, and they're just not good enough results yet to be able to say. There is some research in depression using ketamine, but not depression in people with dementia, so we don't know that yet. And there may be sort of case reports out there, but I don't know of any formal research. Other treatments for agitation, music therapy. So there's been more interest lately looking at music that is specifically matched toward the patient. So a lot of the research in the past has been just kind of, use calming music in general. But using music that's directed toward the patient's own preferences may be a better way to go. That's difficult in institutions, which is where a lot of this is done, because you have a whole bunch of patients with a whole bunch of different preferences. But for an individual at home, that is probably the best way to go. Aromatherapy has also been used, and it's been looked at both as inhalation in the room as well as rubbing onto the skin. And where the best data has been obtained is in using lavender oil and lemon balm or melissa oil. And both have shown pretty good results in terms of reducing levels of agitation in patients with dementia. So it's important to remember that psychotic symptoms are really common. This is not something that's sort of at the extreme or outer limits or at the very severe stages of dementia, of the Alzheimer type, of the Lewy body type, or in Parkinson's disease. But extremely common, and psychotic symptoms come on quite early. And there are primary drivers of caregiver distress and of nursing home placement because of the degree to which they frighten patients, because they make patients distrustful of their caregivers and distrustful of what caregivers try to do to help them. And they're really difficult to treat, not only because they are resistant to treatment, but also because the treatments we have the potential for harming the patients. And non-pharmacological treatment, which means things that the caregiver applies, are really our primary way of going at these symptoms and are actually reasonably effective, probably more effective. And when we talk about effectiveness, we mean how well they work balanced with how little harm they do. The treatments that our caregivers can apply are actually more effective than the treatments that we have available to us, which, although some of them are effective, have very high rates of harm. So I will stop now and answer any other questions that you all might have. Yeah.
You talked very well about the first two types of dementia, but I know I have dementia, but I don't know what type it is. What would be another cause for dementia?
The question was, what would be another cause for dementia?
Yes.
So there's a fairly long list of causes for dementia. Anything that anything that affects the brain has the potential to cause dementia. So stroke can cause dementia. Traumatic brain injury can cause dementia. Here we see people, other causes of dementia, people we see here are multiple sclerosis, cerebrovascular disease, Huntington disease, yeah. So I was talking mainly here about the primary diseases that cause psychosis in neurodegenerative disease.
It was very informative. I liked
Well,
it.
thank you.
But like you said, I have multiple sclerosis, and that's what causes my dementia,
Mhm.
and it mostly affects my memory.
Mm-hmm.
I have to write everything down or I forget it.
Yeah.
Okay. Well, thank you.
What is the percentage of Alzheimer's patients who are violent toward themselves and others?
What is the percentage of Alzheimer's patients who are violent? I don't have an exact number for you. I would guess it's under 10% though. In terms of, do you mean in terms of habitual violence or who have ever done something violent?
No, habitual.
Habitual, I would guess it's fewer than 1 in 10.
Has there been any observation or research in having someone make 20 speeches to themselves? Lance, you may have psychosis, talk about it, all these different situations that we can put on record now and then put it in our face when called for, or we do the same thing saying, well, that's a lie, that's not really me there, or would it help some people? Have you seen people try that?
Has there been observational research? So you mean when someone sort of has their faculties about them, you have them sort of explain to themselves in a recording maybe the things that they do when they're not doing so well, and then play it back to them?
20, 30 things that could possibly happen.
And then play it back. I don't know if anyone's done research on that. I've certainly seen stuff like that in movies, but I don't think I've seen any research on it. It does seem to make sense, although I've had at least one patient who wrote to himself in sort of a good state of mind, and then read it when he was in not so good a state of mind, and he looked at that and said, oh, I'm in my normal state of mind now, and this is what I wrote when I was crazy. So, the level of, it's just this massive reinterpretation of the world that occurs when someone's delusional.
Seriously, there would be lots of reasons to deny it, but
Right.
I would hope there's a percentage of the time that it might work.
Yeah. No, I would think that there might be people out there who would be able to respond to that, or at least elements of it.
Mm-hmm.
Yeah, but I haven't seen research on that. A question at the remote site?
What about high sugar? High sugar causes people that have
Yeah.
psychotic?
Yeah, what about high sugar? So both elevated and low sugar can cause psychotic symptoms. Hallucinations and delusions can occur. It tends to occur more with high sugar than with low sugar, but I've actually seen that with both, yeah. And you don't have to have dementia. So I've seen people who were hyperglycemic with elevated blood sugar who have been psychotic, who did not have dementia.
Well, I'm thinking from the viewpoint of the patient. What you call psychosis might be a normal reaction from somebody who thinks they're losing control of their world. The world isn't the same as when they had control of the world, and they'd like to get the world back to where they're in control.
So give me an example of what you mean.
Well, suppose they have to be taken care of by a caregiver, where before they didn't need that. They were in control of their world, and so maybe what you're calling a psychotic reaction, that's normal. They'd like to be back in control of the world.
So you're saying that the reaction of a patient that is being called psychosis may be simply a normal reaction.
Yeah.
Well, I think that's why we want to
Out
be.
of control.
I think that's why we want to be careful about defining psychosis as not simply being difficult or oppositional. We want to define it as a disconnection from reality, specifically a delusion or a hallucination or a disorganized thought process. So someone saying, I don't need your help, is not psychotic behavior. It may be oppositional, but we wouldn't say that that is psychotic. So I think I would agree with you on that point, that shouldn't be called psychotic behavior. Okay.
I would like you to describe a little bit more about when you should take someone to the emergency room with a psychotic episode. And let's say there's a patient that's had maybe some at home or had some psychotic symptoms, but you were able to manage that. At really what point do you take someone to the emergency room? And when you get there, what do you really need to tell the staff at the emergency room?
So describe a little bit more about what would make me tell someone that the emergency room is the right place to be, I think, and then
Right.
what you should tell them when you get there. So I think the probably suddenness, the rate at which the change has occurred would be the biggest red flag to me, indicating the need for an emergency room visit. I say a lot to people, we get asked all the time, and I think it's an appropriate question, what can I expect over the next year? And often the past predicts the future. So if things have changed quickly over the past 24 hours, then you can expect them to change quickly over the next 24 hours. And that's what kind of drives my thinking in terms of when to advise someone that the emergency room is the best place. The other things that maybe make me think emergency room more is when you have frank neurological symptoms in addition, and he can't walk, and she's not moving her left side, and she's just not alert. So when you have things that are more quote unquote physical symptoms in addition to the behavioral symptoms, that also worries me a lot, because then it starts moving me more towards thinking stroke, seizure, something along those lines. And then what to tell them when you get there. I think you want to impress on the emergency room the suddenness of the change. You want to impress on them that my doctor told me to come here. And that this is not him. A lot of times, I can't tell you the number of times I've seen an emergency room note that starts off with 70-year-old man with dementia. I don't know any good way to change that, but it's like as soon as they hear that someone has dementia, then all of a sudden it puts this completely different lens. It doesn't matter if someone has dementia or not. If they suddenly started hallucinating within the last 24 hours, dementia makes no difference. There's something wrong that just went wrong. So really impress on them that this is a sudden change. That's really the most important thing. And then stress those physical symptoms, the same things that sort of lead to the urgency in my mind. I think you want to impress on the people there. And we try when we can to tell people what to say in the emergency room, but that's also something that, you know, I think that's great that you asked that question to give you all the advice. Ask your doctor when they say, take him to the emergency room. Ask your doctor, what are the things I should tell them when I get there? Tell him he has a fever too. Just say it.
That's a great point. Give them a hard, if they give you a hard time when you tell them, you know that they're not really responding to what you say, the doctors there aren't. Is there an organization or somewhere you can call that you know of that would come in and help you out with that?
So you're saying if the emergency room is not responding,
Yeah, if the doctor is not saying, yeah, you know, if he's kind of watching and he's not saying this is really important, that he's not looking this as an episode that needs to be treated, and you're kind of aware of that, is there somebody you can call or an organization?
if the organization is not, if the emergency room is not responding, is there someone you can call to get them to pay more attention? So most places will have a sort of a patient representative or an ombudsman that you can contact. There's always the doctor who told you to go to the emergency room, if someone told you to go to the emergency room. And there probably is some state organization, but I doubt that they have anything that's a rapid responding kind of situation. It will almost certainly be something where you have to report to them the whole episode of what happened and then they go back and investigate. There's probably some investigative branch. But I think that probably your best bet, I think hospitals are supposed to have posted or give you information when you come in and you sign forms saying that you agree to be at the hospital, some number that you can call if you're not getting satisfactory service.
Is there a guy called a hospitalist? Do they help you?
The question is there a guy called a hospitalist? Yeah, there are doctors that are called hospitalists. Hospitalist simply means that that's someone who only works in the hospital. So they are either hired by the hospital or contracted by the hospital to take care of patients who are admitted to the hospital. They don't have a particular role in making sure that you get great service or anything like that. In fact, most of the hospitalists in Las Vegas, if not all of them, don't work for the hospital. They work for a hospitalist organization, and then the hospital contracts with that hospitalist group for these people. So they don't, as far as I know, have a particular allegiance to the hospital. So yeah, there is a hospitalist, and that's, in a lot of the hospitals, that's who takes care of the people in the hospital, but that's just a physician. They don't actually have much of a connection to the administration of the hospital or to getting things done if there's unsatisfactory service. That's the person who's giving you the unsatisfactory service. I mean, if you're getting unsatisfactory service, that's not their job.
Patients with psychosis are at greater risk for, say, elder abuse because maybe people won't believe what comes out of their mouth because at the time it's not true?
Our patients at psychosis are at greater risk for elder abuse. I don't know if there is anything showing that. My experience has been that patients with psychosis are at greater risk for getting neglected in medical situations. So I've had patients admit, when I was an inpatient doctor on a psychiatric unit, I've had multiple patients admitted with acute medical problems, including heart attack, including status epilepticus, which is ongoing seizure. That happened to me twice, where their medical problems were pretty evident. I mean, these were all diagnosed upon my admission of the patient and were missed in the emergency room or called down to see a patient who was in the middle of a stroke. He won't talk to me. He wouldn't talk because he was aphasic and neglecting. So I suspect that patients, not just with psychosis, but with psychiatric problems, are at risk for their medical problems being missed.
Okay.
Thank you.